Tom Starzl is often referred to as the father of liver transplantation, but to view his career in this context would be to overlook its much broader significance. While others have contributed to the evolution of transplantation and immunology, there are few instances in which a single individual has been so predominantly responsible for establishing a new field. Francis Moore, a former president of our college, sometime rival of Dr. Starzl, and acknowledged spokesman of American surgery, said this:
"He's often been called a great transplanter. Well, with all due deference to transplantation, he's much more than that. He is one of the great biomedical scientists of this century. Tom Starzl soon emerged virtually to stand alone in the breadth of his studies and the depth of his scientific penetration."
While growing up in a small town, Dr. Starzl enjoyed the usual activities of other boys. In 2005, he reminisced about his background and two less usual activities that he had. One pointed him in the direction of surgery.
My mother was a nurse, and she had a great admiration for surgeons. By osmosis, I had a feeling that these were good people. And then I came in contact at an early time when I was in junior high school with a surgeon named Wen Downing. He arranged for me to come to the Sacred Heart Hospital, our city hospital, which was run by nuns, to witness surgery. So I went there on a number of occasions, and he actually gave me anatomy lessons. So I had quite a good deal of exposure to hospitals and specifically to surgery. I was allowed in the operating room at a very young age. So I think my destiny was determined.
Another uncommon childhood experience for Tom was working on the town's newspaper, which was owned and published by his father. This may have given him a start toward being a gifted writer who would one day become the most highly cited medical writer of his time.
Well, I went through, I wasn't allowed to be the boss's son at all. I had to work my way up from the ground up, starting as a newspaper carrier, and then I worked as a printer, but at the lowest level, as a devil. And then I learned printing and learned how to use the linotype. And then I served as a reporter. And my father was quite interested in having me learn all levels of the profession, or all levels of publication. So the journalism part came at the very end, after having gone through all these humiliating lower grades.
During medical school at Northwestern, Starzl developed a serious interest in neuroscience and dropped out for a year of full-time research at UCLA, which resulted in a PhD in neurophysiology. As a surgical resident at Johns Hopkins, he developed a model of complete heart block in dogs and its treatment with the first epicardial pacemaker. As he was finishing his residency in Miami, Dr. Starzl turned his attention to the liver. At first, his research in dogs was not aimed at liver transplantation as a potential therapy, but at using the procedure to study changes in the liver and its metabolism if it was deprived of nutrients and other elements in portal blood.
I got a lab, a garage, and built a lab down there in Miami while I was, at that time, still a senior resident, and was investigating the effect of the kind of blood used to nourish the liver, what its origin was. And I did these, tested different ways of providing a blood supply to the liver, and right away recognized that there was something special in blood coming back from the pancreas and from the intestines. So that was liver transplantation entered by that back door. Liver transplantation was a good way to study this physiology, and so in order to do that, I developed the operation known as liver transplantation, liver replacement. And I did that by hooking up the liver in different ways, different kinds of blood supply. So all that took place at a time when there had not been any kind of organ transplantation. Never had been a successful kidney transplantation from anyone other than an identical twin. So it was during that period in which there was nothing but a giant vacuum that the operation of liver transplantation was developed just for physiologic studies. But then, by the end of the time, and that period of time was 1958 to 1960, for the first time experimental drugs showed up on the horizon, and I thought, wow, this operation that I developed for other reasons could be used to treat people that were dying of liver failure. And so I made that modest proposal as my lifetime project.
Starzl next spent 3 years at Northwestern University, first as a thoracic surgery fellow and then as a junior faculty member. He continued to work on liver transplantation in dogs. Since he did not yet have immunosuppressive drugs, these were studies of unmodified rejection. Just as he had observed earlier in Miami, a provocative finding was that an occasional recipient recovered from rejection.
That I referred to myself at one time as a missile searching for a trajectory. I was bursting with energy. I really wanted to do something that wasn't conventional, wasn't going to be bread and butter surgery as a means of making money, but I wanted to do something important that would have a life of its own, that would endure. I found the trajectory at Northwestern with the transplant studies because I spent about 2 years of full-time duty, worked all day, every day on that project. So the models were in unmodified animals that received no immunosuppression. So basically, the real opportunity here was for the first time to study the rejection patterns of liver allografts. Now, one of the interesting observations that was made in those untreated animals, that we encountered an occasional recipient who rejected, who became jaundiced, and then spontaneously recovered or started to recover. So even before the availability of immunosuppression, we, or I at least, had a very clear idea that rejection was potentially, even without treatment, spontaneously reversible.
In 1962, Starzl moved to the University of Colorado, where he began to evaluate the new immunosuppressive drugs. By adding prednisone to Imuran, he was able to reverse rejection. This was a landmark, never before accomplished by others. It allowed consistent success of liver and kidney allografts in dogs.
I went out to Colorado, and by that time I had contacted Burroughs Wellcome and gotten my own supply of Imuran and took it into the lab on a very intensive basis throughout the late winter and early spring and summer of 1962. And found out how to use it, how to most effectively use it. I first went to Colorado with the determination to check this drug out with livers, because that's where I was going. But I came to realize that, rather quickly I might say, that this operation of liver replacement in dogs was much too difficult, too fraught with technical problems to evaluate a immunosuppressive drug. So we switched gears and made a strategic determination that we would not attempt liver transplantation without succeeding first with kidney transplantation. And that's really why the kidney program was started. It was considered a preliminary step to liver transplantation. Within the first few months of 1962 was to obtain a supply of the drug from Upjohn, I think was the company, and the 6-mercaptopurine and the Imuran were byproducts of that research. So I obtained a supply of Imuran probably about a year after Roy had the drug and had tested it in London and then with Joe Murray in Boston. And I made some observations that were completely missed by the people that had their first crack at the drug. I had treated always with Imuran alone, and then only when rejection developed in the dogs did I add the steroids. And I found that rejection was always reversible, or essentially 95% of the time was reversible. And that sometimes you could then stop the steroids, and to our amazement, most of the liver recipients did not reject.
Encouraged by these animal results, he began to perform human kidney transplants. He was pleased to find that his unique immunosuppressive protocol was just as effective in humans, resulting in consistent survival of their kidney transplants. This landmark finding came at a crucial time. Until then, the results of others had been so poor that continuation of human trials was violently controversial, being labeled by many as futile or even unethical.
I think the greatest liability in terms of professional criticism and disgrace was with our first cases of kidney transplantation, because the perception was, at that time, worldwide, the perception was that this couldn't work. It had been tried. There had been a number of cases tried, perhaps as many as 200 around the world, at Harvard and in Europe, in France, in England at the Hammersmith Hospital, and also at UCLA, and in Canada also, Cleveland. They had all failed. And the people that had made these efforts were by and large extremely pessimistic. This was still in 1962. We were watching what was going on in Boston, and we were in communication with the people in Boston about what was going on with the first clinical trials of Imuran, the results from which were very poor. At the Brigham, I think they did the combination of the Imuran trials at the Brigham and in England by Roy. They did 4 cases in England. Were quite discouraging. There was only a single patient out of the first 14 or 15 that lasted for as long as 6 months, and those were all terminated by death. So it looked like the kidney field was dead in the water.
In 1963, Starzl presented his results at a small conference of the National Research Council. It was a watershed event. About 25 of the world's established transplant experts were gathered to share their experiences. About 200 human kidney transplants in all. The results were terrible. Only 10% of the recipients had survived 3 months, and only 6 had lived a year. Immunosuppression for most had been whole-body irradiation. It was now hoped that the new drugs would bring improvement. But of Joe Murray's 10 Imuran-treated patients, only 1 had survived 6 months. Thus, it appeared that the new drugs were no better than radiation. The mood at the conference was so gloomy that it was considered whether further human trials could be justified. Gloom at the conference was then dispelled by the presentation of Tom Starzl, who was a newcomer to the field. He described 30 patients with 80% success. This was more surviving patients than the rest of the world's experts combined. Skeptics in the audience became convinced by charts that he brought tracking the daily progress and lab studies of the recipients. Starzl's presentation caused a sensation and completely changed the outlook for transplantation. Boston transplant surgeon and historian Nick Tilney said it was like letting the genie out of the bottle. Many of the conference attendees promptly followed Starzl to Denver to learn his methods. His immunosuppressive protocol then became the world standard for the next 2 decades.
So we came along armed with some information from the experimental laboratory about drug combinations and made that operation, kidney transplantation, just work almost routinely. And it created a revolution in the field. And not only that, we did something, we had demonstrated that rejection, the big barrier, was reversible. No one had known that before. And also some of our animals, when we stopped drugs, didn't reject. So this looked like a pathway that would lead to liver transplantation, but then the ceiling fell.
Despite his extensive experience with liver transplantation in dogs, achievement of success of the procedure in humans proved to be very difficult. In 1963, Starzl's first patient bled to death on the table. The next 4 survived the operation but died early deaths from infection. At this stage, most people might have followed the advice of their colleagues to give up. But instead, Starzl, during a 3-year self-imposed moratorium, refined his technique in animal experiments and introduced a new immunosuppressive agent, anti-lymphocyte serum. These adjustments allowed Starzl to perform the world's first successful liver transplant in 1967. 3 early recipients are shown here by Starzl's fellow of the time, Carl Groth. Other successes followed, but for another decade the procedure remained only a qualified success.
So between 1967 and the time I moved to Pittsburgh, or until the time that cyclosporine became available, was 1967 to the tail end of 1979. So there was a long period of time in which there were multiple successes, but the survival rate was only 50%.
Right.
And losing half the liver recipients, not just from loss of graft, but from death in the first during the first year was a very tough pill to keep swallowing, and never during that more than a dozen years seeing any way that that I could improve things. So I was completely dependent on finding or having somebody else take the next step. And so when Roy came up with Cyclosporine with a report in 1979, I was all over the company to get a supply of the drugs and try it.
In 1979, the miracle drug cyclosporine was introduced by Roy Callan. First used as a single agent, This drug was potent, but so toxic that it might have been abandoned. But Starzl rescued it. By lowering the dose and combining it with prednisone, he showed that it greatly improved results, another of his landmark contributions.
There was a great deal of debate. The cyclosporine story you're very familiar with. Cyclosporine was introduced first, and then the Sandoz had actually made a decision to take it off the market because of the tremendous toxicity of the drug as it was originally used. But that change really did revolutionize liver transplantation because the 1 year survival before then had been about only 1 in 3. Afterwards, it was 2 out of 3 or better. Technology has become so perfect and so useful in the treatment of human disease that there's an enormous demand for it. It's not some weird little thing that gets done once in a while. It's a
viable treatment.
Oh, it's a tremendous advance, and conceptually, it's maybe the greatest advance ever in the history of medicine.
In 1981, Starzl moved from Colorado to the University of Pittsburgh. Over the next decade, he and his team worked at a furious pace. They performed as many as 600 transplants a year. Their results continued to improve, especially after 1989, when Starzl introduced tacrolimus, a new drug which has now become the standard. The level of success with liver transplantation soon reached 90% or better. Liver transplantation now was no longer considered an experiment, but an established therapy. A few of Starzl's other accomplishments during this period included initiation of intestinal transplantation, the first successful pancreatic islet allografts, demonstration that liver replacement would cure many inherited metabolic abnormalities, and elucidation of the liver's control of lipid metabolism. In 1990, Starzl was forced to take time out to have an operation on his own coronary arteries. Despite a full recovery, he elected not to return to operating. Later, he was asked why, and whether he missed operating.
I didn't actually say I was going to retire. I just said that I was going to stop doing surgery. And in fact, on that occasion, the occasion of the announcement that I wasn't going to be doing surgery, I was made director of the Transplantation Institute at the university, which is a job which would almost preclude doing surgery because it is such it has such large responsibilities that there's no time left. I was relieved to get sick and have an excuse to stop, but bear in mind I was almost 65 years old at the time, and also I was too much emotionally ruined by the loss of people that I came to love, and I always felt like in some way if somebody died who should have lived or could have lived, that it was a doomsday event for me. No, I didn't miss it at all. Of course, the retreat was this all came to a screeching halt in 1990, and I went back into research again, and that turned out to be quite good too.
Starzl's comment that his return to research was good turned out to be an understatement. His aim now was to explain why rejection was reversible, why allografts ever worked, and whether tolerance could reduce or eliminate the need for chronic immunosuppression. In 1992, Starzl discovered that the key to these questions was chimerism. This was another landmark finding, one that was at least as important as his other breakthroughs.
In 1992, a search was made at this hospital and especially at Presbyterian for donor leukocytes in 30 kidney or liver recipients. These patients had borne functioning grafts for up to 3 decades. Using sensitive immunocytochemical and/or PCR techniques, donor leukocytes were detected in one or more of the recipient's sites, shown in this liver recipient, in the blood of all 30 tested patients. Because these cells were sparse, their presence was called microchimerism. The discovery in 1992 of microchimerism signaled a paradigm shift in transplantation.
For decades, it had been assumed that since allograft survival could often be attained without administration of donor cells, chimerism must be irrelevant. Starzl's demonstration of donor cell microchimerism in long-standing recipients indicated otherwise. The finding dramatically refocused attention on the role of chimerism. Because Starzl's patients had not been given donor cells, the chimeric cells he discovered could only have reached them as passengers migrating from the donor organ. Most of the patients were off all immunosuppressive drugs, thus appearing to be tolerant. The crucial role of chimerism was at first controversial, but is now widely accepted. It strongly supports Starzl's concept of a two-way paradigm that tolerance is the result of the response of coexisting donor and recipient cells, each to the other. As Tom Starzl approaches his 9th decade, he continues to go to work every day, always accompanied in his office by his beloved dogs. Although he's grateful for the opportunity to spend more time with Joy, his wife of 34 years, he often finds this difficult, since he remains so busy with research, writing, lecturing, and accepting awards. His bibliography of more than 3,000 scientific publications continues to increase. This has made him, by a wide margin, the world's most cited medical scientific author. Tom Starzl is certainly the most widely honored living surgeon. In Pittsburgh, buildings and streets are named for him. He has 19 honorary degrees from U.S. and foreign universities and 20 honorary fellowships of surgical colleges of other countries. He has been given the highest awards of our college, of the American Surgical Association, the Transplantation Society, the Institute of Medicine of the National Academy of Sciences, and many others. He's a member of the American Philosophical Society and the American Association of Arts and Sciences. He has received the National Medal of Science, the Lasker Award, and this year he became the only surgical member of the National Academy of Sciences. From this sampling of his scientific contributions, one cannot fully appreciate the importance of Tom Starzl. Perhaps a fitting closure to this session are his own comments on the progress that has taken place in the field of transplantation during his time.
What looked to be a hopeless dream, fantasy, has become a regular and very reliable service. It's a process that essentially was complete by 1990, and since then there's been some little fine-tuning. But it's gotten so good that the only limit to transplantation is the fact that there aren't enough organs. He transformed the philosophy within 1 or 2 generations that guides medicine, because until the last 40 or 50 years, if you had somebody with end-stage heart disease or liver disease or kidney disease, there was really nothing you could do except try to squeeze out the last day of life-sustaining function, and that's all she wrote. And then all of a sudden turn into the next chapter, and you can replace the whole engine, not just a spark plug or two. So it totally changed the philosophy by which medicine is practiced.